Hello again. I'm not a very good YouTuber, so for those that followed me in hopes of new information after the last video, my bad. Alright, I'm making this one all on my own, not representing my employer or the federal government in any way. I'm even rocking my shutdown beard, so you can tell it's been a minute. But I was inspired to finally make this video based on this article that came out in Nature. I'll leave a link to it in the description, but shout out to Natalie Healy for writing what I think was an excellent piece. The article articulates what the medical community is finally starting to realize about topical steroid withdrawal, or TSW for short. After prolonged steroid use, topical steroid use, even if they're tapered off, patients can experience a full body reaction. And it's important to note that new symptoms can occur on part of the bodies that never before had eczema or atopic dermatitis or any other skin disorder. Thus, they can happen on parts of the body where steroids were never applied. These new symptoms that come on after this discontinuation can include burning, flushing, in a sense that the person's temperature is abnormal, even if their thermometer doesn't suggest that they have a fever. Other changes can include how the itch feels, going from kind of a superficial itch to what they describe as like bone deep, where it's, you don't feel like you can satisfy with just scratching the skin. There are other abnormalities, like the skin starts to emit unusual odors. There can be a sensation of electrical signals going through the skin, which the fancy word is neuropathy, but patients often refer to these as zingers, and many other symptoms that are distinct from underlying eczema. And this is important because patients understand that how their eczema feels, and they know that these symptoms are something new and something different. If you want to learn more details about this, I highly recommend reading the article and watching the documentary called Still Preventable by Brianna Banos. I'll leave a link to that as well in the description. It's a free documentary you can find on YouTube. Both the Nature article and the documentary mention work from my lab, which I've discussed in my last video for those that are interested. If you want those details, I would watch that video, but the very basics are that we evaluated patients who had TSW versus patients who know that they have eczema or eczema-like diseases but don't have TSW, and then compared them to healthy controls. The overview of the biochemistry is summarized here. The short version of it is on your mitochondria. You have something called the electron transport chain, which is how your body generates energy. Complex 1 of the electron transport chain takes NADH, which it gets from breaking down tryptophan, and turns it into NAD+, or niacin, and then that just recycles and renews over and over again. Normally, the body can recycle it just fine, but for reasons that are still somewhat unclear, patients with topical steroid withdrawal have numerous copies of complex 1, and that causes them to just churn out way more NAD than they would normally be doing, and so to try to recycle that, they break down more tryptophan than what would be normal, and breaking down tryptophan creates these neurotoxic intermediators, which can explain the itch and dysregulation, as well as changes in the way the body sweats and flushes, and skin proliferation and other inflammatory markers. Now, while our study did receive some foolish nonsense commentary, there are some legitimate limitations to our study. We did not evaluate children, so even though the disease is less common in kids, we can't really know for sure that the exact same mechanisms are at play for children as they are in adults. Our study only had a small number of people, which is not itself invalidating, but could mean that some of the more unusual forms of TSW that might be out there were not included in our study. And like I said, we failed to identify any obvious reason why some people get TSW after long-term steroids, but most people seem to be just fine. We also failed to find any obvious laboratory value that you could send off and then tell somebody, oh, this is TSW based on this particular biomarker. But all of that, and again what was discussed in the Nature video, that is what was missed about TSW. That is not why I wanted to make this video. I wanted to make a video about why I think it got missed. I think a lot of people reflexively think that the reason the medical community is slow to recognize TSW is the influence of Big Pharma. And I am absolutely not here to claim that money has no impact or doesn't create perverse incentives. But I would say that while companies on the whole make a lot of money on selling topical steroids, because these drugs have been around for so long, I don't know that there are any researchers specifically who are standing up to defend them because of some kind of profit motive. I might make a video, again, it might take me a while because I'm a terrible YouTuber, but I might make one about how money actually corrupts the biomedical research, because I don't think it happens the way people like to think that it happens. If enough people express interest, maybe I'll put that together. But for now, let me just say that as it relates to topical steroids, I just don't see money as being the primary influence or the main problem. All right, so what might be the problem actually be? Well, let's start. Science kind of knows what's going on in severe eczema. I don't want to pretend that we understand all of it, but we know that certain markers of inflammation, what we call cytokines, are abnormal. Things like IL-4 and IL-13 are elevated, and these are blocked by drugs like dupilumab and tralokinumab, and that's why those drugs can be helpful. T cells are abnormal in the disease, and these can be blocked by calcineurin inhibitors or steroids. And the microbiome is disrupted, and lots of other things. All of these contribute to a breakdown in the barrier function, that is the ability of the skin to keep moisture inside and prevent the outside world from getting into our system. Patients with TSW have all of those abnormalities as well. They just have the additional problem with their mitochondria. I'll note here that others have thrown out other hypotheses for TSW, like abnormalities in nitric oxide or in the expression of the steroid receptor itself. Those don't yet have the data to back themselves up as being the cause of the disease, but I'll mention them here that it could be more than just the mitochondria. But whatever you think is going on in TSW, you kind of start to wonder why no one ever found these abnormalities before. Why didn't anyone who was studying severe eczema, for example, stumble across a subset of patients with abnormalities in their mitochondria or nitric oxide or steroid receptors? And so to answer this, I'm going to use the analogy of mixing colors. Part 1, the color of the windbags. All right, so let's say we have healthy controls. We're going to make them orange. Patients with severe eczema who do not have TSW, we're going to say they're blue. And patients who are labeled as severe eczema, but who actually have TSW or who also have TSW, we're gonna make them yellow. If half the patients labeled as severe eczema were actually TSW, then when the entire group was analyzed as a unit, their data would kind of blend together, and it would look like the healthy controls were orange and the patients with severe eczema were green. When the researchers dissect out why severe eczema appears green versus orange, they would have found a large number of patients were blue and a large number of patients were yellow. And they would have identified what we would term subtypes or endotypes. But if only 5 or 10% of patients labeled as severe eczema actually had TSW, that might not be enough to shift the overall signal. That is, when the group was analyzed, it would appear that healthy controls are still orange, but patients with severe eczema would be still blue, or maybe at best light blue. If anyone evaluated the details, it would look like most of the people were blue, and then there were just a few outliers who didn't quite fit that pattern, but the overall averages would stay the same. But it's even worse than that, because remember, the patients with TSW have all those same features of atopic dermatitis or eczema, including the most obvious ones like itch and rash, but they have a shared cytokine profile and T-cell abnormalities, Staph aureus overgrowth. They just have additional problems. So the analogy really isn't blue versus yellow. It would be that the patients with TSW are blue-green. They are themselves a blend of some of the markers of severe eczema and have the additional TSW problems on top of that. So if only 10% of the patients were bluish-green, well then certainly when you studied severe eczema, the overall group would look basically blue, and you might not think to dig any deeper because you'd want to focus on those shared features of severe eczema that's distinguishing it from the still orange healthy volunteers. Now, I just want to be clear though, when I say only 5% of patients with severe eczema had TSW, that's still a lot of people. And the concern that, well, it's a small number or might be a small percentage of the overall population does not excuse them being dismissed as having only eczema. So this issue of TSW blending in with eczema is not just a problem for overlooking biochemical differences. It could explain how otherwise well-meaning providers could miss this. This is me giving people a lot of grace here, but okay. If 9 out of the 10 patients with severe eczema that a medical provider sees are really just that, patients with severe eczema, and 9 out of the 10 patients with severe eczema a provider sees are improved by treating them as if they have severe eczema, then the provider might see that one person as someone who's not listening to medical advice rather than someone who has a completely different diagnosis. I'm not saying that as an excuse for gaslighting or dismissive attitudes, and I'm definitely not excusing the lack of curiosity shown by those that should be investigating this disease. especially after the patient advocacy groups that formed made it very clear that some of these patients had something new. But I could see a provider incorrectly thinking that patients complaining of TSW are just people with underlying eczema because 9 out of the 10 patients they see with severe eczema are people with undertreated eczema. Now, the idea, of course, that TSW could blend in with eczema can be an explanation for why it's missed, but it could also be used as an excuse. The most frequent excuse I hear when you mention TSW to a provider that's hesitant about the diagnosis of TSW is that it is rare. Okay? The first problem with that, of course, is that you don't actually know that. If no one has bothered to collect the data, you can't possibly tell what the risk actually is. The only actual study performed on this was all the way back in 2014. He predicted that it might be about 12% of all severe eczema patients. Now, he runs a referral center in Japan, so that might cause him to concentrate some patients into his clinic and might make that number a little higher than it could be. But those are the only numbers that we actually have. All you might be able to say, and I really want to stress that word might, is that TSW occurs in a low percentage of people who use topical steroids overall, and there is still a low percentage of patients who use topical steroids chronically. That too doesn't have any actual data behind it, but at least it would be consistent with that color change analogy that I presented earlier. Because again, I think if half the patients who were labeled as severe eczema actually had TSW, I do think researchers would have figured that out a long time ago. But even if TSW only occurs in 12%, or even if it's 1 or 2% of patients on chronic topical steroids, that is not rare, because the number of people who are given long-term topical steroids is very large, especially as eczema becomes more and more frequent. A small percentage of a huge number is still a lot of people, and none of them needed that fate. TSW is... Now, this is where listening to the patients in detail should have overcome some of these biases, because like I said, patients with TSW report having completely new symptoms, particularly on parts of their body that were never impacted before, and many report a change in the nature of their previous symptoms. So some patients who were only mild eczema before, after the TSW began, they suddenly could be considered severe eczema. And so the idea that TSW is just undertreated eczema kind of falls apart because so many patients are describing a disease that is obviously expanded or at minimum significantly changed. But again, this is my best attempt at showing grace. You know, the idea that medicine was blue-green colorblind, so to speak, is my most supportive presentation of what went wrong. But that, it comes as a little bit of a stickler when I come up with the next most frequent excuse and rationalization given when you talk to providers who are skeptical about TSW. It's something along the lines of, I don't know how to diagnose it, or I don't know how to recognize it. Kind of implying that they think it might be real, they just don't know enough to make the call and to give the diagnosis to some of their patients. So to this, I'm forced to ask, what have you done to remedy your ignorance? Unless you actually desire ignorance, did you look into it at all? Did you talk to patient groups to get a sense of why they think they have TSW and not just eczema? Did you read literature from researchers who do feel comfortable about their ability to recognize TSW, like Dr. Peter Leo? For those who don't know, Peter Leo has basically been the tip of the spear in the medical world fighting for TSW recognition and increased testing. Other than the patients living through the disorder, Dr. Leo is probably the world's expert on what patients with TSW deal with and had a great study showing some benefit of dupilumab in TSW. In our paper, we performed something called a penalized regression model, which is just a $5 word for saying that we asked a computer to sort through over 1,700 responses to tell us how we could distinguish severe eczema in people who don't think they have TSW from people who said that they had TSW. We were able to derive some preliminary diagnostic criteria to kind of answer that question of how you would tell them apart. And there are other groups out there who have much more clinical experience who were using that to derive their own very similar guidelines, which we all hope will be published very soon. But while I don't expect everyone to run a regression model or derive your own diagnostic criteria, if you're a provider and you're responsible for knowing how to diagnose the patient sitting in the office and you just tell them, I don't know how to tell TSW from eczema, kind of feel like our next question should be, how hard did you work to try to figure that out? I think if those in the field were willing to admit that they missed TSW because those patients blended in with severe eczema, I think that would go a long way. But I don't think that admission alone would be enough to spur on the type of systemic changes that we need to improve the research apparatus in the future. While we should all be excited about the numerous better options for patients with atopic dermatitis, with the needed caveat that many of them are unaffordable for most of the people in the world. I doubt that topical steroids will be the last drug that has an unrecognized complication related to chronic use. So that leads me to my next section of where I want to discuss the more structural issues that help explain why TSW was missed for so long and why in some cases it's still being missed. Part 2. It's just eugenics all the way down. I think there are two structural problems that led to TSW being dismissed. The number one, the pattern of acting like every disease is caused by an innate defect in the patient. And number two, the role of how medical providers see themselves. The first one I talk extensively in my book, Gattaca Has Fallen. You can check out my book and its admittedly absurd page count. If you read my book, you'll see that I'm very adamant that the core flaw in biomedical research is this reflexive belief that any disease that manifests represents some kind of innate flaw in the patient, even if that's only said implicitly and without any judgment. Once an environmental cause can be found, then you can see the paradigm shift, but it is always very slow. For example, the famed statistician and eugenicist Ronald Fisher, the guy who made a lot of the math that we use in population genetics, wrote not one but two Nature papers outlining that he felt that the connection between smoking and lung cancer were genetic. That is, he believed that people have the genes for lung cancer and also have the genes for smoking, but that smoking did not cause lung cancer. For the second paper, he actually teamed up with Joseph Mengel's mentor and former Nazi scientist to advocate for this particular position. Obviously, I don't think anyone would take that stance today. So no one would ask, if drinking makes people drunk, why doesn't everyone that has a drink get inebriated? Well, there we all know the size of the person relative to their drinking, whether they have an empty stomach, prior tolerance from drinking, all can play a role. So maybe you could argue, all things being equal, why might one person get drunk? But you would first need to account for all those differences in exposure before assuming that a person that drank a bottle can't hold their liquor while a person who had one shot was a born sailor. As it relates to eczema and pretty much most common disorders, I think we still operate under that dogma. If one kid gets eczema while their neighbor is totally healthy, or especially if one kid gets eczema while their siblings are healthy, it is seen as a sign that there must be something wrong with the impacted kid. Again, not even meant to be demeaning, it's just something must be flawed in that child for why they got eczema while other kids in their house or on their block did not. We hold on to this despite the fact that rates of eczema have skyrocketed when you compare them to ancient times. Now, in some cases, a rise in a disease rate could be nothing more than increased recognition. But humans have been able to recognize eczema since before the pyramids. And even as late as the 1970s, the rates of eczema in the United States were low, maybe in the range of 2 to 5%. Today, just one or two generations later, depending on how you want to count, the rates are 15 to 25%. That pace of rise, especially when coupled with other data, including how migration impacts your risk, or kind of screams out that the disease is caused by an increased level of exposure to some kind of environmental factor. If I showed you a graph like this for obesity and some kind of modern rise, there wouldn't be much question that the environment was to blame. Similarly, if I showed you a reverse graph showing a decline in the rates of tuberculosis in some parts of the world, the reason would be obvious for everyone. The humans have changed their environment and reduced the risk of exposure to tuberculosis, and thus the disease has gone down. So when you see a disease rise to this extent, you should scream out that there is something in the environment that's creating that. But when you ignore the environment, instead focus only on the idea that the patient's physiology needs to be fixed, that leads you to believe that the only fixes are, by definition, a drug. Now, that statement might be a little eerily similar to, let's just say, the least reliable corners of the wellness influencers, but that's not the same thing as saying that doctors or researchers are bought off. It's just that they are focusing on trying to solve a problem the only way they really can imagine how, which is finding a new pharmaceutical to help. So after years of the rates rising and rising, people kept searching for some magic drug, and there was little earnest effort involved into the environmental factors. Again, the assumptions were that kids that, quote, live in the same environment, if one has a disease and one doesn't, must be something wrong with the kid. But you didn't really ever see anyone define what it actually means to live in the same environment. If a mom smoked with her first kid but not the second, would those kids be in the same environment just because they grew up in the same home? What if they had exposure to pets or financial stress or antibiotics, or maybe a factory opened up after one of your children was already born? Is exposure to that factory problematic? There are hundreds of different things that are different between two siblings, so you couldn't just assume that the environment was the same because they happened to share the same address. So my lab has done a lot of work evaluating environmental drivers of eczema, and I have a video in my collection here. If anyone wants details on that, you know the drill. The link will be in the description. When you realize that eczema is environmental, that should cause you to re-look at the disparities of the disease in race, geography, or income. Instead, we get some of the experts, like one that was quoted in the Nature story, Emma Gutman. She has several papers out that assume innate racial differences must be the cause of differences in disease rates. She has papers that have graphs like this one, where she wants to talk about Asian eczema or African American eczema based on a surprisingly small number of people who are poorly defined as what that even means, without collecting a single environmental variable, such as what skincare products people might use, or where they lived, or what other exposures, or even whether or not they were born in the United States before presenting to her clinic. Now, there's no excuse for that scientific racism, but the idea underneath it that caused people to go chasing after some new drug was successful at times. Plenty of new drugs have been recently discovered, which have given people happiness who were previously miserable. But it's still not totally sustainable, because there's no world in which everyone will be able to afford all of these new drugs, and certainly it is unwise to continue to generate disease and then hope you can find new treatments with medicines that will have their own side effects, like we saw with TSW. Basically, I think we spent 2 to 3 scientific generations chasing after the gene for eczema, and that caused a lot of people to make assumptions or outright ignore the environment or microbial contributions. This brings me back to TSW, specifically where a similar dynamic is at play. You can see people assuming that, well, plenty of people get topical steroids and they're fine. So if these people have problems, it must be something wrong with them. They're not using the steroids correctly. They're using a high potency on the wrong parts of their body. It's got to be something wrong with them. And even the ones that support you might think, well, we have to go find some biochemical treatment to reverse this problem rather than avoid it in the first place. You can see that in the response from the doctor quoted in the Nature article I mentioned at the beginning. She comments on the author's observation that abruptly stopping topical steroids can cause the disease to return, to which she replies that patients may interpret this as withdrawal, but in my view, they were never treated appropriately in the first place. This, of course, assumes that patients are somehow unable to tell their baseline eczema from their new TSW symptoms, and does not really answer why she, a person who runs one of the most well-funded skin disease laboratories in the history of humanity, didn't bother to run a study to confirm her suspicions that this was not steroid-induced. When you have the resources to investigate if the person in front of you is having a catastrophic reaction to a drug you gave them, I don't see how you can justify not running some sort of evaluation. But it might be even more shocking when you see the other doctor quoted as a detractor to TSW in the Nature piece say that she's never seen a patient with TSW, because you need to realize that she works with Dr. Leo, like at the same institution. Now, if you had a coworker who told you they had a real live unicorn in their office, you'd be totally right to be skeptical. But you would, I would think, take a peek inside the office and see before dismissing them as being completely wrong. It's also a little tone deaf because this doctor doesn't seem to realize that anyone who suspected that they or their child might have TSW would actively avoid seeing her in the clinic due to the types of statements she's made in public that have sent out a clear signal that she does not take this disease seriously and does not think that it is real. So maybe part of the reason that you've not seen any of these cases is both because you haven't bothered to go look for them, and any cases that are out there are actively avoiding you. All right, so I think that about covers the eugenics adjacent assumption that I think patients who are impacted by a disease are thought to have something wrong with them. Obviously, if you want to read that in much more detail, you can check out my book. However, I think TSW has another aspect layered on top of this, which is the threat that it poses to physician or provider identity. People often get very defensive when someone presents information that threatens how they see themselves. And so in this final part, I'd like to talk about that. Healthcare providers like to think of themselves, among other things, as helpful, caring, and educated. admitting TSW is real takes a fairly common treatment and places some big restrictions on it. That is, you would need to limit topical steroid prescriptions to no more than 4 months, and some of your patients might want to avoid them entirely due to the risk, even if those risks were perceived as being small. In part, this is still in line with that thinking that if it's genetic, you have to treat with a drug, but doctors are often not trained on non-prescription or environmental or dietary options that people can try. So some might reject TSW because it would take away a potent tool in their toolbox, and they worry, well, what else can I provide? How am I going to be helpful if I can't prescribe this? This is why I think dermatologists who prescribe the most topical steroids have more trouble with TSW than fields like mine and allergy or the infectious disease docs I work with. We don't really use topical steroids enough to view them as a substantial portion of our ability to provide care. But it does say that we want to be helpful, and these drugs can be helpful. So when you take that away, you are attacking that doctor's identity. Dr. Leo has made a great guide for clinicians, which I'm going to call the Leo ladder because he's too humble to call it that. It outlines what options providers could use if their patients don't want to use topical steroids. The Leo ladder is a reflection of respecting patients' wishes and trying to work with the person as best you can, which might actually help that caring part of the identity. See, the caring identity is endangered if a provider has ever been dismissive of someone with TSW. If they blew someone off before, then admitting you were wrong would mean, at least for that patient, you were being uncaring. It also means that you might have to realize that your prescription practices left at least some of these patients badly harmed, and no one really wants to admit that. The final one about being educated is also threatened because the big names, like those cited in the Nature article, the providers like to think that reading the latest paper or seeing the latest lecture at an annual meeting is a sign that they're educated about a topic. So when big names are out there telling people that this isn't real, the ability to parrot that talking point actually becomes a badge of being educated. Outside of the peer review process where we were trying to get our paper published, I've not had any bad interactions with any real doubters. Maybe they don't want to say things to my face, but we've had doubters that have come along, and they might say something like, Dr. Big Name says that it's actually a subtype of eczema called erythrodermic atopic derm. I can quickly see the sense of understanding that they think they have erode very quickly by just asking them, how does Dr. Big Name say we should distinguish this subtype from other types of eczema? What are her diagnostic criteria for this erythrodermic AD, or what biochemically separates it? When they don't have an answer for that, they kind of have to admit, all right, well, maybe I don't know as much as I think, and they want to now become educated, and I think they're more open to listening to other ideas. So my hope is that our work in our lab will allow people to start to feed into that physician or provider identity by believing in TSW, particularly with the help of the write-ups like in Nature and other news outlets. Reading about our work might become the latest info, and thus awareness rather than denial could be seen as a sign of being educated. The problem, of course, is that I'm an allergist and not in those dermatologist spaces or in their pecking order, so I may not be seen as the authority to point to the way the detractors would. But maybe these coverages help, and maybe protecting patients from the risk of steroid will become a sign of being caring, which forces providers to think about other non-steroid options like on the Leo ladder. We will see. So overall, I don't think that accusing physicians of being beholden to pharma, at least on this topic, is valuable or even accurate. I think our medical system, to a disturbing degree, our entire culture, is built on the idea that people's innate natures, such as their genetics, set up a sizable or at least meaningful degree of their disease risk, when in reality, for most diseases, genetics are a negligible contributor to disease, even if they're technically not zero. But for TSW, I think admitting a wrong this meaningful is also seen as an attack on physician identity. Perhaps the new openness to the diagnosis can become an opportunity to enhance that identity rather than detract from it. So it might be another year before I make something, so sorry in advance. Like I said, I'm a bad YouTuber, but I think I'm supposed to say like and subscribe now. I don't know. Whatever. Please do check out the Nature article. It isn't paywalled, so anybody should be able to find it searching for the title there. Or like I said, it'll be in the description. Please do watch Still Preventable, freely available on YouTube. And obviously, feel free to check out my book if you would like to read a lot more about the unintended consequences of focusing on genetics. With that, I'll just say, be well.